We'll go through clinical implications of the observed association between tuberculosis and cardiovascular diseases. And thank you again for the invitation. This has been a lovely meeting so far. These are my faculty disclosures. I wanted to highlight this first clinical statement on post-TB health that was published a couple of years ago. And it included a section of post-TB cardiovascular disease. And we tried to focus on four major cardiovascular risk factors that may be overrepresented in our patients with TB and post-TB, such as tobacco use, hypertension, diabetes, and some patients may have dyslipidemia as well. So you will find over there a very nice table that goes through these four major risk factors. This was put together by Jamila. We were tasked at that time to try to come up with more practical recommendations. And of course, smoking is a major risk factor for cardiovascular disease, frequent in our patient population, and doing appropriate screening and going through smoking cessation strategies on those who are active smokers is definitely a need. Then the other major risk factor is diabetes, and doing appropriate screening. Thankfully, globally, most TB programs nowadays are doing this routinely, either with an A1C or a fasting blood glucose. And for those who have diabetes, making sure that there is adequate glycemic control, including lifestyle as well as dietary advice, and then there is pharmacologic management as well. Hypertension is very important, and sometimes this is not necessarily taken in consideration in TB programs, and I think that we should stress on that. And based on regional guidelines, doing the appropriate screening as well as doing the appropriate blood pressure control in those who have high blood pressure. And that includes lifestyle advice, including diet, physical activity, weight management, as well as reduced salt intake. And dyslipidemia is the same, making sure that there is appropriate screening, age and sex based for lipid dysregulation. So in general, I think there is an opportunity and there is a need for routine cardiovascular and modifiable risk factor assessments. These, for example, in our clinics in the US, we try to use some risk calculators, such as the American Heart Association pool cohort equation, or the most recently validated PREVENT calculator that also accounts for GFR as well as BMI. And there has been a question in the field of whether TB should be considered a cardiovascular risk enhancer, and I think with some of the data that Matt and others have shown, I think that the answer is yes by now. Now, whether more targeted, intensified cardiovascular screening or prevention strategies specific for people with TB or post-TB are indicated, that does require more studies, but then trying to make sure that we are following our primary care guidelines on cardiovascular and modifiable risk factor assessment is really important. And then the other is making sure that we are promoting integration of our TB and non-communicable diseases programs. So the best way to do that is still to be determined, but some of this work could be started at our TB clinics, and then follow-up could be done at not necessarily the TB program, but some of these already established non-communicable disease programs. And you may not be able to see this very well, but this is part of our primary prevention of cardiovascular disease guidelines, where based on the estimated risk of the patient, you may already, if there is an estimated risk of 5% or more for a cardiovascular event in the next 10 years, there may be an indication for a moderate intensity study. And I wanted to refer you to this box over here that has the risk enhancers. And in there is a bullet point that talks about inflammatory diseases, including HIV, psoriasis, rheumatoid arthritis. And I think that's the place where having tuberculosis, there is already enough evidence to consider tuberculosis within this list of risk-enhancing conditions that may push you towards doing primary care prevention, for example, with the statins or other measures a little earlier rather than later. And there I wanted to highlight the work that Friedrich and colleagues are doing, where they are looking at statins, not necessarily for their lipid lowering effect, but more because of their pleiotropic effects, specifically in the TB population. So more to come in the next few years on that. I wanted to highlight also work from Kamila Romanowski that looked at interventions to mitigate common non-communicable diseases. And in there was a mention of cardiovascular disease interventions. But the overall conclusion there was that further evidence is needed to really look at feasible and effective ways of how these interventions could be scaled up at a national level, at a program level. The other work that I wanted to highlight as well is work coming from Matt McGee's cohort in the country of Georgia and partially led by Argita, that shows that hypertension is prevalent in patients who are starting TB treatment. And not only that, but the incidence of a new diagnosis of hypertension within the 12 months of TB treatment completion is actually relatively high, 28%. And if you look at the risk factors for incident hypertension in patients with tuberculosis, you have the age as well as male sex, but also cavitary lesion was a risk factor in this particular analysis. And I also like the approach from Sarah and others that try to learn from other fields. And I was just bringing up this example from the HIV field, where it has been very well modeled, very well calculated, how much we could prevent from these downstream comorbidities if we, for example, do prevention of smoking or prevent total cholesterol and hypertension. So if we think about approaching these major risk factors such as smoking, hypertension, diabetes, we may be able to decrease the downstream effects on post-TB cardiovascular complications quite significantly. And then another example comes from the COVID-19 in an overall picture, right? There is very well established literature that shows that the most efficient way of preventing post-COVID conditions will be vaccination, right? And there are studies that show that. And even though we don't have a vaccine yet in the TB field that will prevent pulmonary TB in adolescents and adults, once we have that, that may have implications down the road, not only for PTLD, but also for post-cardiovascular disease. And the same question could come up for TB preventive therapy, right? What will be the downstream effects of TB preventive therapy at a major scale with all these post-TB complications? And I wanted to finish, this is the one slide that I have on preclinical work, that basically we asked this very fundamental question of whether mycobacteria infection will be sufficient to aggravate atherosclerosis, and the answer was yes. And we published this a few years ago, and now we have done experiments where we give these mice, for example, core antibiotics, anti-TB antibiotics such as isoniazid and rifampin, and unfortunately, we do not see that atherosclerosis goes away with antibiotic treatment alone. But when we start adding, for example, in this case, we did an anti-CCR2 monoclonal antibody that modulates some of the inflammatory responses as well as recruitment of monocytes into vascular tissue, we start seeing that there is reversion of that infection-aggravated atherosclerosis in the mouse model. So there is a potential for host-directed therapies, but then the question will come up as well, how much of these is going to be potentially implementable at a large scale national program level. So the take-home messages, I think, from my side was trying to show you that there is a need and there is an opportunity for routine cardiovascular and modifiable risk factor assessment during TB and post-TB care, and trying to focus on smoking, diabetes, hypertension, kind of the major drivers of traditional cardiovascular disease will be important and of good serve to our population. Then we need to think about better ways to integrate our tuberculosis and non-communicable disease services, and the question of whether our TB clinics, our TB programs can take on the initial cardiovascular risk assessment and maybe identify those patients who need additional follow-up after they complete TB treatment. And more research is needed for sure. Andrew was talking about this within the whole TB spectrum to better understand the mechanisms. I show you some data on atherosclerosis, but for example, in Africa, ischemic heart disease may not be the the most important driver. There is a lot of evidence these days that is showing that non-ischemic cardiomyopathy is really one of the main drivers of cardiovascular disease and heart failure, and how TB is affecting the myocardium, and the pericardial disease related to TB is also important. So we can figure out interventions, and then among these interventions we can figure out which of the interventions are really the ones that can be scaled up at a national level TB program approach. So with that, I wanted to thank you, and happy to, I don't know if there is time for questions, but the three of us will be happy to answer questions at this point. Yeah.